So in this case, we have a 45-year-old female. She called the ambulance because she was feeling a little nauseous, maybe threw up once, and then her family noticed that she was quite sweaty. This all occurred after exertion. So the arriving EMS crew, they performed a 12-lead ECG, and that's displayed right here. We're going to go through this in a normal stepwise approach. We're going to first evaluate the rate, and like with most of these electrocardiograms, it's usually calculated for you, and we're getting 108, but we can confirm that with, let's use the 300, 150, 100 rule. So we'll find an R wave. This one seems pretty good. To here would be 300, this would be 150, and then right here is just a little bit ahead of 100, so 108 seems like an accurate number. From there, we're going to look at the intervals, more specifically trying to make sure that we have all of the waves that we need for a normal sinus beat present and that they are occurring at regular spaces between one another. So we've got P waves. These are pretty regular. Our QRS complex appears to be narrow, and the computer is calculating it less than 120 milliseconds. And then our QT interval seems appropriate as well. The end of the T wave is right around here. If we measure it from here to here, we can see that it is in fact less than 400, and so that is within a normal range. Now it comes down to looking at axis, and we can see we've got a normal axis. This QRS complex is facing up, and this QRS complex in AVF is also up, and so we have a normal axis, no axis deviation to be found here. From there, let's look for some ischemia, and when we look for ischemia, we're going to really just scrutinize all 12 leads and then see if we can find any patterns, specifically any ST elevation or ST depression that can be found in multiple leads that offer a similar view of one side of the heart or another. And so if we start off here at lead 1, we can see that the ST segment, and I'll blow that up, doesn't look all that good. There's a couple of things that should jump out at you at this point, and one of them is that if you compare the PR segment to the ST segment, and notice that the J point is right here, you'll see that it is in fact elevated up off the baseline by about 1 millimeter. Now, keep in mind that per STEMI criteria, with the exception of the precordial leads, so V1 through, I think, V4 or V3, you really only need greater than or equal to 1 millimeter of ST elevation in order for you to be concerned that this is, in fact, an MI. Now, because we have this finding here and this person has a concerning story, we're going to take this finding very seriously. If we move down the electrocardiogram, starting off in lead 1, which we know is a lateral lead, we'll move down to the inferior leads, 2, 3, AVF, and we don't see so much in the way of ST elevation, but we do see some ST depression. And that's going to be most prominent here in lead 3. If we zoom in on one of these complexes and look at like the PR segment and the TP segment, we can see that there is about 1 millimeter of depression. Now, this is important because in the setting of lateral ST elevation, so the lateral leads meaning lead 1, AVL, and then the V6 and V5 leads, having a reciprocal change is important for reinforcing our suspicion of STEMI, and lead 3, being that it looks at the inferior aspect of the heart, will help reinforce that suspicion, and it is a reciprocal change. Moving on to AVR, which is usually the opposite, more or less, of what AVF would look like, we can see that there is some evidence of depression. It's very, very subtle, and if we look at the PR segment, it's about 1 millimeter. And then if we take a peek here at AVL, we can see that the ST segment is also elevated slightly off of the isoelectric baseline. And because we have both abnormal ST changes in lead 1 and AVL, and then we have a reciprocal change in an inferior lead, this gives us a very strong suspicion that this person is experiencing a STEMI because we have ST elevation in 2 contiguous leads and then a reciprocal change. And let's look at AVF. Yeah, the T waves look a little, maybe just a small amount of depressed, but we're not really seeing anything as profound as we are in lead 3. We look out to the precordial leads. we've got a little bit of ST elevation here, but it's not necessarily the amount that we would get concerned over. V3 looks all right. Let's see, V4 looks okay. Oh, actually, no, maybe not. V4 looks like there's a little bit of elevation here as well if we measure that PR segment. And then as we make it down to the lateral leads, being V5 and V6, we can also see that there is a millimeter of elevation off of the PR segment. So based off of these findings, remember that in the setting of a STEMI, it's important to have findings that are consistent with a similar area anatomically of the heart. V1 and AVL are your high lateral leads, whereas V5 and V6 are your lower lateral leads, but they're all looking at the lateral aspect of the myocardium. And so the fact that we have ST elevation in these leads as they are grouped with the addition of ST depression in the reciprocal viewpoints, that being lead 3, and to a degree, well, I guess maybe not so much in AVF, but in lead 3, mixed with the concerning history of present illness, makes us come to the conclusion that this person is experiencing a lateral wall STEMI.